Hi everyone, good evening, good afternoon, good morning, based on the location that you are right at this time. I think we can start if you can hear me.
Yes, please.
Am I audible to everyone, guys?
Yes, please. Let us continue.
Yes. Yes, you are.
Okay. Thank you very much and welcome everyone for the very important meeting, which is an meeting for the being moderate by our beloved friend and chair of the TORG-IRB. But over the last couple of days, he was not feeling good, and he's now doing great. And we also wish him to have a very speedy recovery. So on behalf of Mr. Hailemar, appearing and so my name is Nursen in
Hello, everyone. Let's just give him some time to reconnect. I think it's network issues. Thank you.
Can you hear me now?
Yes, let us continue.
Yeah.
Okay. We are lucky enough that the TORG-IRB is composed of dedicated and vibrant scholars who are doing their best to make it a very competitive and well-recognized entity internationally. And over the last couple of months, the chair, Mr. Hailemariam, and the secretary, Dr. Kevin, and all the other members have been doing their best, and they have now achieved some achievements, some success that we can tell right now. They have reviewed their first proposal, which is on the WHO surgical safety checklist, and they have also sent us their review on the second proposal, which was developed by the global research team and our president, Professor Adegusola, and it was about biomarker identification for postoperative delirium. And the other one is they have also been recognized by renowned international organizations based in the US, and they are the organization is called Office for Human Research Protections, and they have also get their IRB number every identifiers. And what does this mean for the TORG-IRB and for our organization for TORG? This means it strengthens the credibility and integrity of all research conducted under our organization. It also ensures our research activities that they meet international standards, recognized ethical standards, and enhances the protection of human subjects involved in TORG-led studies globally. It also builds trust among partners, collaborators, and communities we serve, and it also opens great opportunities for global research collaborations, scholarly publications, and research training initiatives. So it also put TORG as a leader in ethical research governance in global surgery and allied health fields. So today's meeting, as I have tried to mention it earlier, today's meeting is an inaugural ethics congress, which is with a team of ethics in global surgery research, which is foundations, challenges, and best practices. So we have featuring expert insights on different topics. The first one is the global frameworks in surgical research ethics. The second one will be practical challenges with vulnerable populations. The third one will be modern surgical paradigms and future perspectives. So we will also have activities to do. So some of the activities are we will have someone who is going to read the biography of our speaker one, who is Mr. Dr. Abid Ashraf, which will be introduced by Dr. Yusuf for 5 minutes, and the presentation will be also another presentation will be continued by Dr. Abid Ashraf on ethical foundations and global frameworks in surgical research. This will take about 20 minutes, and the second one will be just introducing our second speaker, who is Mr. Siraj Ahmed, which will be done by Assistant Professor Damaka Ilkal. This will also take 5 minutes. The other activity is going to be presentation by Mr. Siraj Ahmed, practical challenges, best practice in research ethics and vulnerable populations. And he will highlight on the consent issues, community engagement, cultural considerations, and what are the IRB perspectives for this one. So this will also take 20 minutes. The other one is the introduction of speaker 3 by Mr. Mesfin Ababa. Our third speaker is going to be Dr. Kevin, who is the secretary of our TORG-IRB, and he will be using about 20 minutes, and the topic will be ethical practice in modern surgical paradigm and future perspectives. So this will also take 20 minutes. And the highlights are artificial intelligence, robotic surgery, robotic surgery. These are the highlights that are going to be presented by Dr. Kevin. And the next activity will be, we will have a 15 minutes questioning and answer session, so that we will proceed like this one. And the last one is going to be discussions, which are going to be questions forwarded from attendees or participants of this session. And they are going to be addressed by the speakers and the moderator and by our president, Professor Adewshala. So these are the main activities. Lastly, there will be a closing and key takeaways, which will include final thoughts from the moderator and announcement of upcoming engagement opportunities. We will also talk about these matters. So these are the things we are going to do. Thank you very much for listening, and I would like to allow our speakers to continue their presentations. Thank you very much. Are you guys there?
Yes.
So
Yes.
we will proceed with the
Hello.
first activity, which is going to be the biography introduction of the first speaker, who is Dr. Abid Ashraf by Dr. Yusuf. So, Dr. Yusuf, please proceed, and you can continue introducing Dr. Abid Ashraf for about 5 minutes.
All right. Thank you very much, everyone. Can you hear me?
Yes, we can hear
Yes.
you.
Thank you very much. Yeah, good afternoon and good evening, everyone. It's a great honor to introduce our first speaker today. Our first speaker is a general surgeon and a laparoscopic surgeon currently working in the Gulf of Asian Medical Center in Saudi Arabia. Apart from being serving on the Institutional Review Board of the TORG, he's also a founder for the Upper GI Surgical Society, and surgeon based in UK. He holds a membership of the Urea College of Surgeons in Edinburgh, and he also serves as a peer reviewer in many journals, including BMJ, Springer, BMC, and Sage. So our speaker has worked vastly in the area concerning the subject he will be presenting on, and I mean we will be very glad to hear him enlighten us on his experience regarding the subject matter, which is on the discussion point. So our speaker is no other person but Dr. Abid Ashraf. Doctor, thank you very much and welcome.
Thank you so much. Thank you for the kind introduction, and good evening, everybody. So I guess we get started with things. I'd like to share my screen. I hope it's visible to everybody.
Yeah, it is visible, Dr. Abid.
Yeah.
You can proceed.
So
Yes,
just a second. So today we'll be delving into the basic ethical foundations and some insight into the global frameworks in surgical research. We'll be underlining key principles and international standards that actually shape up surgical research. So the prime objective is to examine how these guidelines and frameworks actually impact real-life patient safety and drive various innovations and development in modern surgical practice. So there are four basic principles to consider, as is true with, as is true with clinical practice as well. There's an overlap. So the four principles are autonomy. This is the most fundamental. Autonomy, non-maleficence, justice, and beneficence. So what autonomy means that patients' rights take precedence over everything else, even if it comes at the cost of the surgical or the medical innovation. So the basic thing is to respect the participants' right to make an informed choice about their involvement in research. Okay. we'll be discussing these things in a bit of a detail in a short while. So the other fundamental aspect to be considered when it comes to ethical issues in surgical research is non-maleficence. We have to ensure that we don't do any harm. So researchers must always avoid causing unnecessary harm to participants. And the third important principle is justice. This has been a subject of a debate for pretty long. I'll come up with some examples later on. So justice means we have to ensure fair selection and treatment of research participants that represents all demographics and not, focusing on a particular community. So the fourth principle is beneficence. Research must be useful to the general population without, of course, the attendant risks. We have to ensure that we minimize the risks to participants. So what autonomy means that patients have the ultimate right to decide about taking part in the research. Their values and preference take precedence over everything else, including the scientific objectives we aim to achieve. So this is the fundamental thing, that actually drives research as well as medical practice. But it's very important to understand that consent is not a one-time event. It's not about signing a form. So it is a continuing process. What that means is that patients have a right to withdraw from the research at any point of time without any consequences. So it does not need to be a one-off event. And of course, this consent has to be informed. What that means is that there has to be a full disclosure of the intervention that we are about to study, the proposed intervention, and the attendant risks, including the unknown risks. For example, if we are, researching an innovation, or we come up with an innovation, we are researching a modified technique or a newer technique for a disease, the surgical technique. So like, the development of robotic surgery and other things. So it doesn't come with a, considerable set of evidence to back. So there are certain things that are still unknown while you adopt a newer technique, a newer device. So the patients have a right to understand that there are attendant risks and there are unknown risks. So we cannot justify, the lack of information, the lack of transparency by just citing that the procedure contemplated or the research being conducted is a bit complex. So to sum it that autonomy actually rests on this basic premise that patients are partners in research, not just experimental subjects. Their integrity, dignity, their perspectives demand utmost respect, regardless of the scientific imperatives. Non-maleficence, it's based on the principle that we don't do any harm. While conducting the research, the basic aim should be do no harm, primum non nocere. So that's the crux of the research, that in disguise of achieving better things or better scientific progress, we don't actually end up harming the participants. And this is not something that is new. This ancient principle has been in literature, although not much organized, but since early times. So what actually non-maleficence entails, we have to rigorously assess the harms against anticipated benefits. So, as you know, surgical interventions inherently involve risks that are, not attendant to other forms of research. So that's where surgery is a bit different. Surgical research is a bit different because we have real and potentially serious risks involved. So this also means that we have to, develop, design protocols, taking into consideration that the protocols or the proposed research causes minimum pain, for example, discomfort and complications, minimum risks. Okay. And in most of the good centers, we have safety monitoring boards that provide independent oversight. So why this is important is that non-maleficence actually means that you have the courage to terminate the research when the participants face unexpected risks, even at significant scientific cost. Even if you have made significant scientific progress and you feel like the results are quite imminent, but if there are unacceptable risks, you should have the courage to terminate the research. Justice. Justice means that there has to be equity in surgical research participation. The study population must span socioeconomic and demographic boundaries. Exclusion criteria should have scientific, not convenience-based justification. So what this means is that whatever research is being proposed, it must represent the population, not just a specific community. Okay, and it should be a meticulous selection, not based out of your comfort. And the surgical advances that we aim to achieve should extend, to the entire population, not just a specific group. Research protocols should actually address implementation in resource-limited settings. We have to keep in mind that there are constraints with resource allocation in different setups. So the protocols need to consider those things as well. Burden distribution means that the risks of experimental procedures cannot fall disproportionately on marginalized groups. There's one example on this. I'll come to that later on once we discuss Belmont report. So there have been historical exploitation patterns, particularly concerning the Global South, where research were conducted and the burden fell on a specific community. So this actually demands pretty much, vigilant approach and strong measures to counteract this, irregular burden distribution. To sum it up, justice demands that the participants who bear risks of surgical research should actually be benefited, regardless of their socio-economical and demographic position. Beneficence. That means we advance care through ethical research that entails principles like active promotion of good. We should actively pursue the patient beyond the standard care. Benefit should extend not only to future patients, not only to current patients, but future patients and broader populations, even beyond the studied demographic. And all this is to be done by aiming for risk minimization. That protocols must include safeguards that exceed the standard clinical practice. You have to keep in checks. You have to keep checks in place to prevent, risks and untoward effects, untoward results, untoward fallout. Researchers must continually reassess risk-benefit thresholds throughout the studies. As I made it clear that this is a continuum. So you have to reassess things at every point of time while doing research. So it's not a one-off event that we actually assess the risks at the start of this research and forget about things and continue with things. So there has to be a continuous reassessment at different stages of the research. And what drives the beneficence is therapeutic intent. Surgical innovations should address genuine clinical needs, not just merely for professional advancement. So as this actually rests on the principle that patients' health takes priority over everything else. So it's not merely for professional contentment or professional advancement. Surgical innovations should actually be, intended to address challenging clinical needs. Patient welfare, as you know, must remain central. So beneficence actually does not necessarily mean just avoiding harm. It demands proactive creation of meaningful benefits that justify surgical intervention risks. So there are some intrinsic challenges when it comes to research in the surgical disciplines. Like we have methodological limitations. Like in a lot of surgical studies, randomization and double blinding is a bit difficult to implement. Suppose you have an established surgical modality for suppose you have an established surgical modality for a particular disease. So now, if you want to, test it against some other newer approach, so that's going to be a bit bothersome because the risks would be too much and it won't be a nicely randomized thing. And then there are risks as regards the innovations, like newer procedures and tools often used without robust evidence of efficacy or safety. And then what actually is most concerning in the current scenario is industry influence, where the corporate sector actually drives, at least partially, the innovations and has considerable influence on the studies. So that has the potential to skew the results in one direction. So this actually crops up as conflict of interest. There are financial entanglements that industry funding can actually influence even the study design, interpretation, reporting, application. And then there are institutional pressures, like particularly for professionals in their mid-career level, where they have the stress to actually, aim for better, more publications and career advancement. And at some point of time, they may end up compromising the research integrity. So the best thing to actually avoid this conflict of interest is transparent reporting of all potential conflicts. This not only maintains the integrity of the researcher, but also promises research validity. So proper management would require vigilance, a voluntary disclosure, and sometimes a recusal from the researchers. So the global ethical frameworks in surgical research, the most prominent ones are Helsinki Declaration. This has been going in update since 1964, the latest update being in October 2024. Then there are WHO guidelines, there are local regional laws, there's a US common rule that provides legal foundations for research protections, and then there are professional standards set by professional societies. It would be a bit exhaustive to talk about individual, guidelines. So I will just go through a couple of those. So it all started with the Nuremberg Code. That was the first international document establishing voluntary consent as absolutely necessary. So in 1964, the World Medical Association adopted Declaration of Helsinki. This was, primarily this actually, focused on physician-driven ethical principles for medical research involving human subjects. Then in 1979, the Belmont Report was framed. This established three core principles: respect for the participants, beneficence, and justice, and laid down the frameworks for achieving the respective things. And in 2000s, digital ethics have started to come up to address the, newer modalities like AI, robotics, and the big data that's in our theaters nowadays. So the Helsinki Declaration actually formed the cornerstone of surgical research ethics. So in 1964, there was an original adoption, and it's being reviewed continually. So the key revisions as of 2024 are: it not only strengthened requirements for informed consent, there's a post-trial access to intervention that has been proposed, a research registration. Nowadays, you actually have a lot of things, like if you are, for example, doing a systematic review, you can register it on a portal like Prospero, just to increase the transparency and prevent plagiarism and other things. And publication ethics have also been included. So the core principle reflected throughout the Helsinki Declaration is that the patient's health is a priority. Nothing else matters more than that. It not only, this declaration not only transcends to, legal jurisdictions, it serves as an ethical foundation for surgical research globally. And its principles have formed the foundation of some of the national laws, institutional policies, even the journal publication ethics. So the main principles of Helsinki Declaration are the primacy of patient welfare. So the research participants' well-being takes precedence over everything else. And voluntary informed consent. Participants must provide an informed, freely given, without any pressure, consent after a due and thorough comprehension of the research purpose, the methods, the risks, and the benefits. And as I said, that the consent has to be continual. Okay. Third thing is scientific validity requirement. Research must be methodologically sound and justified by potential value of the knowledge to be gained. So, and it has to have a favorable risk-benefit ratio. If some research is attendant with an adverse risk-benefit ratio, must not be pursued. The declaration also mandates independent ethical review. That's where the institutional review boards come up. Privacy protections and equitable selection of participants. These principles actually form the foundation of IRBs worldwide. So the current standing is that since 2013 revision that we call as modern framework, that was done to strengthen the provisions for post-trial access to beneficial treatments. Vulnerable populations were protected. There was a provision for their protection and compensation for research-related injuries. And all clinical trials must now be registered in publicly accessible databases. You have portals for the registration of studies. Before even the recruitment begins, this actually enhances transparency and prevents publication bias. And this has expanded the informed consent with the inclusion of biobank research, incidental findings, and data sharing considerations that were absent in earlier versions. Nowadays, the consent has to include a statement on data sharing as well. Another, basic set of guidelines that's being followed worldwide is Belmont Report. This was originally published in 1979. This actually established the fundamental ethical principles, more in line with the Helsinki Declaration, but this provides a structured framework to achieve those. So the main principles are respect for persons, like autonomy, protection for those with diminished capacity, the vulnerable population, and this forms the basis for informed consent. Beneficence, like maximizing benefits while minimizing harm, and justice, equitable distribution of research benefits and burdens, preventing exploitation of vulnerable populations. The difference is that unlike Helsinki declarations focus on the medical aspects, the Belmont Report emerged from the need to address specific research misconduct in United States, including the infamous Tuskegee syphilis study. I'm not sure whether I'm able to pronounce that correctly, but there was a concern in this study that, the control group belonged to a particular community and they were not made aware that they were not giving the treatment for syphilis while it was, being treated by penicillin in the intervention group. The control group were kept, uninformed, and they hailed from a particular community. There's another set of guidelines, that's Council for Medical Innovation and Operative Standards. So this was established in 2003 to address the unique ethical considerations because of the emerging surgical techniques and technologies that traditionally, that the more traditional frameworks didn't address, like with the advent of AI and robotics. So this has become all the more imperative. So it pioneered a three-tier system, distinguishing between minor modifications, significant variations, and entirely novel procedures, each requiring different levels of oversight, ethical oversight. For example, a minor modification might not need a vigorous level of scrutiny, but a more significant variation or an entirely novel procedure would require a very vigorous oversight. So there's a learning curve transparency that is to be maintained. You have to, do an explicit disclosure of surgeon experience with novel procedures, requiring clear documentation of the learning curve phenomenon in informed consent. These guidelines actually breach the gap between innovation and patient protection, acknowledging that surgical advances cannot wait for the timeline of traditional clinical trials, while still ensuring ethical safeguards. So unlike Helsinki and Belmont, which broadly address research ethics, CMIOS guidelines specifically tackle the surgical innovation pathway. That's pretty much relevant these days, and my colleague Kevin will talk more about that. So this emphasizes equipment standardization, surgical training requirements, and conflict of interest management in device development. So how to do oversight? There are research ethics committees and boards. This actually ensures an independent review. All surgical studies undergo thorough evaluation by independent committees before approval. And a risk assessment, committees carefully weigh the risk benefits, the methodology, and the consent procedures. This leads to a better quality control, preventing bias, data fabrication, and methodological flaws that could harm the participants. And there are some ethical dilemmas in surgical research. For example, the surgeon's role is a bit complex, plays multiple roles. He's not only the care provider and the advocate of the, the newer technique, the modification, but also a researcher at the same time. So there's a potential to actually for the inadvertent bias to creep in. Then there are consent challenges, like ensuring truly voluntary participation in emergency or critical care situations is, a bit of a gray area, and it's not as simple as, in other scenarios. Then there are data privacy concerns, like we have to maintain anonymity while leveraging AI and advanced technologies. And there has to be an exhaustive mention of these things while obtaining consent as well. The cornerstones of informed consent in surgical research are rest on comprehensive disclosure. We have to explain every risk and benefit, even the unknown risks. The potential for unknown risks must be clearly explained in patient's own language, the participant's own language, without the use of technical jargon. Patients or participants must demonstrate understanding and ability to comprehend things and make autonomous decisions. And the entire process has to be voluntary. The participation must remain free from coercion, undue influence, therapeutic misconception, incentives, and canvassing. So the spatial considerations are that the continuous consent for multi-stage surgical trials, proxy consent protocols for emergency situations. You can obtain consent from the nearest of the kin or whosoever is deemed feasible on the basis of the local laws. Cultural competency in international research settings. Remember, as I would like to reiterate that consent is not a single event, but an ongoing process throughout the research journey. So with the advent of AI particularly, there have been increasing concerns regarding data privacy. De-identification protocols must remove 18 HIPAA specified elements from research data sets. Okay. So this is regarding the, patient identifiers. It's a bit exhaustive. So it would be outside the domain of the current discussion. So data storage, encrypted repositories can be kept with controlled access that prevent the unauthorized use of sensitive surgical data. And you must have been aware of the, data leaks from some of the, well-reputed centers. In India, there's, a pioneering center in Delhi, AIMS, All India Institute of Medical Sciences, and that I guess a couple of years back that suffered a massive data breach. So we have to take measures to prevent such incidents. Sharing protocols, international transfers require additional safeguards beyond standard consent provisions. That's why in most of the countries we have an apex body to oversee the sharing of data with other countries. Vulnerable populations are to be protected even in surgical research. For example, children, elderly, cognitively impaired individuals, they need enhanced safeguards because of their limited ability to make informed decisions. The standard consent process may not suffice for these groups. You might have to rope in a guardian or a legally suitable person. Surrogate decision-making, wherever possible, the legal representatives must prioritize participant welfare over research goals. Clear guidelines prevent exploitation of decision-making authority. And as I said, socioeconomic factors should not determine participation. You have to maintain diversity because that enhances the research applicability across populations. So the approach to emerging trends and the best practices we can employ is a rigorous disclosure, complete and transparent conflict of interest reporting for all research stakeholders, and enhanced transparency, not only clear documentation of authorship contributions, AI utilization and comprehensive data reporting have to be resorted to, and a vigilant monitoring. That means a systematic oversight to prevent data fabrication, plagiarism, and protocol deviations. This can be done at multiple levels, including the local review boards and the national as well. And a continuous need for continuous education, ongoing ethics training for surgical researchers at all career stages. Patient advocacy in surgical research. Patient representatives, you can have advocates that ensure participant voices, influence research design and implementation. And as I said, it's best to involve the potential or the enrolled participants not only during the study, but before the study as well as after the study. So these patient representatives can bridge communication gaps between researchers and participants. Empowering participants. Education programs help participants understand their rights and options. Informed participants make better decisions about enrollment and continuation. This is not only beneficial for the final outcome, but for the viability of the study as well, so that there is not, an untoward, decrease in the participation midway during this study. Balancing interests. Advocates help navigate conflicts between research goals and patient welfare. They ensure vulnerable participants receive fair treatment throughout the process. The ethical leadership in surgical research rests on three main things. One is the moral compass. Leaders actually set ethical standards beyond regulatory minimums. The regulatory, guidelines tend to have loopholes. Okay, but where we take care of those loopholes is by having a good moral setup and taking things in a very moral, ethical way. So the moral compass actually helps you to prioritize patient welfare over research outcomes. Ethical leaders foster environments where concerns are freely voiced. They reward integrity over expediency in research decisions. So you might incentivize disclosures, integrity over, expediency or the results. So transparent accountability, readers take responsibility for all the research conducted under their oversight. They implement clear processes for addressing ethical breaches, and that too impartially. What this actually means that the ethical leadership is responsible for transformation of these principles that we discuss into practices that protect patients and advance surgical science. Now, particularly in Global South, we have problems with the resources allocation. So we have to ensure that there's distributed justice, fair distribution of research benefits and burdens across populations. This prevents exploitation of the vulnerable groups for scientific advancement. Balancing commercial interests with genuine patient needs. We might be incentivized to work in a particular direction, but we have to balance it with genuine patient needs. Rare conditions often receive disproportionately less research attention. Global equity, addressing disparities between high and low resource settings. Surgical innovation should not only reach a specific group, it should reach all populations equitably. So ethical resource allocation actually transforms research from the privilege of a few into a benefit for all. Now coming to cultural considerations in surgical research. Cultural competence has to be taken into account always. So research protocols must adhere to this idea of taking into consideration the diverse cultural beliefs about surgery particularly and healing. Even in the 21st century, we continue to have a lot of myths going around when it comes to surgical practice. So the local customs might influence a patient's expectations and the consent process might be difficult considering those things, those notions or prejudices that the participants might harbor. So you have to keep a room for the cultural competence as well. Communication barriers, language barriers create challenge in obtaining informed consent, in explaining things thoroughly to the participants and obtaining feedback as well. So wherever possible, you must use the local language. Translation must preserve both scientific accuracy and cultural nuances. Ethical relativism. This means that researchers must balance universal ethical principles with cultural sensitivity. That means researchers must tailor the universal principles to the local dynamics, avoiding both ethical imperialism, and that's very much in discussion these days. There's every sort of imperialism these days. I guess it was always there, but people are recognizing it more frequently now. And moral relativism requires careful navigation. So the cultural awareness transforms research from a culturally blind to a culturally responsive process, ensuring ethical integrity across borders. Now, there's always an impetus for, creating things. So innovative technologies, novel interventions like surgical robots and AI-assisted procedures have come up. They have raised unique ethical questions. Just as an example, I'm currently working on, analyzing the ethical concerns in the levels of autonomy that a surgical robot currently has. So this has far-reaching ethical implications and legal implications as well. So this presents a very unique ethical scenario. And as of now, there aren't clear-cut guidelines. So but the basic premise still holds true that participants deserve transparency about the technology's experimental nature. So data collection, real-time monitoring actually generates vast data sets requiring robust governance. Nowadays, you have, surgical robots with a real-time, recording of the procedure, and this actually generates a vast amount of data. And how you actually monitor that data, how you actually store that data, that's, pretty much concerning. And if you're going to use that surgical data for your academic purposes, it must need a prior consent. So the ethical evaluation in case of innovative technologies is that innovation should not outpace ethical scrutiny. Even if there are, amazing incentives with a particular innovation, it should not come at the cost of ethical issues. Research ethics committees need proper technological expertise for proper assessment. As with the current, scenarios involving a lot of technology, AI, and other things. So you need a proper expertise if you are going to assess things better. Long-term outcome ethics are concerned about, temporal responsibility. Researchers must track outcomes beyond the standard follow-up periods. So sometimes what happens that we have a predetermined follow-up period for a particular study, and then we stop following the patients. But this must not be done. It should go on, and because especially the surgical innovations may reveal consequences much later after implementation. Novel procedures may affect future generations as well. So the ethical frameworks must consider delayed and multi-generational effects. So something that's being, introduced now might have consequences that we'll come to know maybe 30 years down the line. Data infrastructure, long-term registries require sustainable funding models. So the patient tracking systems must balance follow-up with privacy concerns. So the message is that ethical surgical research acknowledges that true outcomes unfold over lifetimes, not merely the trial periods. Now there's, a concern, like we talked about the cultural impact as well, that, how about the local versus global? So, like we discussed, that there are international universal standards like Helsinki, Belmont, CIOMS. They establish the baseline ethical requirements. These frameworks provide the guidance, but may not address the specific, challenge that are unique to a particular demography, that are unique to a particular resource setting. So the local frameworks have to be evolved that actually rest on these broader principles, but take care of the local dynamics, the cultural impact into consideration. Local realities like research constraints, healthcare infrastructure, community values, these are specific ethical considerations, and while tailoring the local ethical policy, we have to be taken into consideration. The standard of care definitions vary dramatically between high and low resource settings, so this is fluctuating. Ethical navigation means surgical researchers must balance universal principles with contextual adaptation. Success requires collaborative ethics development with local stakeholders and communities. So we have to actually, the universal principles provide a foundation and on which we can build the local guidelines. So we don't have to.
Sorry to interrupt you, Dr. Abid.
Yes.
We have presenters, so if it is possible, it would be great if you just make the presentation faster. And if you finish it
I'll
with
just, I guess I'm left with quite a few slides only. I'm about to conclude.
Okay.
So that's the last one. So
Okay.
just concluding, ethical rigor protects patients' rights. I mean, the participants are the most fundamental thing when it comes to ethics. So at the same time, and it advances safe innovation and makes room for, preservation of public trust. So the global collaboration actually strengthens oversight and improves research standards worldwide. That's why, these declarations, which are widely adopted, have come up. The future of surgical success depends on balancing technical skill with moral values. It should not come at the cost of participants' well-being. And I will conclude with this statement that the patient's welfare or the participants' welfare must remain the focus of all the research we do, regardless of the scientific imperatives. Thank you very much.
Okay, thank you very much, Dr. Abid. Thank you for your well-organized and a very precise presentation. People were saying that we cannot wait to get this important presentation and all the documents in this presentation. So I would like to thank you for presenting us with the most up-to-date aspects about surgical research ethics, including the new updates on the Helsinki Declaration and the surgical ethical aspects of robotic surgery. I really appreciate that. Participants may have the questions or additional discussion points. I kindly ask you to take note of these points, and then later on we'll discuss on these matters. I will now call upon Assistant Professor Demak Ilkal to introduce our second presenter, Mr. Siraj Ahmed, who will be presenting on the practical challenges, best practices in research ethics for vulnerable populations. So, Professor Demaka, you may proceed. Thank you very much. You have 5 minutes.
Okay, thank you, Norusen. Are you listening to me? Is that audible?
We can hear you. Yeah,
Okay,
it is
thank
audible.
you. So I'm gonna to introduce one of the IRB speakers, Siraj Ahmed Ali. He is presenting his on ethics in global surgery research, foundations, challenges, and best practice. So Siraj Ahmed currently is a lecturer, senior anesthetist, and researcher at Dilla University College of Medicine and Health Science Department of Anesthesiology. His educational background, he is a PhD student in anesthesia at University of Gondar College of Medicine and Health Science since June 2024, and has Masters of Degree in Advanced Clinical Anesthesia from Dilla University College of Medicine and Health Science, graduated in May 2019, and he has also acquired his basic degree in anesthesia from Jumma University in June 2012. His academic and medical service experience is more than 12 years of clinical and teaching experience. While we see the leadership experience, Mr. Siraj has various leadership positions at Dilla University, including anesthesia clinical service coordinator, department head, and college vice president office head, currently serving as a president of Ethiopian Association of Anesthetists. While we see his research experience, he has a remarkable research experience with more than 16 publications on international reputable journals. Mr. Siraj is an executive council member and special event coordinator of TORG Ethiopia chapter, and he is member of TORG-IRB, and he's going to present on practical challenge with vulnerable population, timely and critical topics in global health equity, focusing on ethical issues, current challenges, and the like things. So this is Siraj Ahmed, our president of Association of Ethiopia, and I would like to call up on Mr. Siraj to present his topic. Thank you.
Thank you very much, everybody. Can you hear me?
Yeah, it's
Yeah.
audible.
Sure.
Okay. Thank you. Dhammaka, can you share the slides from your side, since my device is not working on Zoom, and join from the other device. So can you share?
Okay. Sure, I'm just trying to share.
No. Okay, thank you.
I'm sorry. It says unsupported document. It's still trying. Is that visible, Siraj?
No, no.
Is that visible?
I cannot see anything.
Nuruse?
Yes, it is not visible.
It's not visible, Dhammaka.
Is that visible for others?
Not at all.
Just
maybe we can go to the next presenter until Siraj is fixing the issues. What do you think? If that's possible.
I think proceed to the third speaker when we ready to present Mr. Siraj. Shall we go to the third speakers to save our time?
Yeah, that would be nice, I guess.
That's good. I think Freedom will arrange and share with his.
No, I shared it. I don't know why it is not visible.
There is no any visible slide here. So we can proceed to the next presenter so that Demaga and Siraj will fix the problems. So we'll come back to you guys. I think for the sake of time, we need to go to the next presenter. So our next presenter is going to be Mr. Kevin Michael, Dr. Kevin Michael, sorry. He is going to be presenting ethical practice in modern surgical paradigm and future perspectives. And before he starts his presentation, I will call upon Mr. Mesfin Abebe, who is a TORG-IRB member, to introduce Dr. Kevin for 5 minutes. Thank you very much. You can proceed, Mr. Mesfin.
Okay, thank you so much, Mr. Nur Hussein. Hello, everyone. So let us introduce our third speaker's biography of Dr. Kevin Michael. Dr. Kevin Michael just earned his bachelor's degree in psychology and his doctor of medicine from University of Santo Tomas. He will soon also pursue Master of Public Health degree at University of Hong Kong. He currently works as hemodialysis and emergency room physician at Zamboanga Doctors Hospitals. He also involved in several public health, mental health, and medical education organizations. He served as a deputy director for community development at Mental Health and a part of Secretariat for Human Rights-Based Mental Health Advocacy Network. Now he also holds a role of secretary, ethics compliance support officer for the operating room global IRB and global research team. Additionally, he also a member of technical and policy committee of the Philippine Society of Public Health Physicians. Dr. Kevin began his leadership journey as a member of executive board of Human Rights and Peace at Asia Medical Student Association at University of Santo Tomas. He also later became a national officer for public health at Asia Medical Student Association at Philippines. As he also has mentor with a top-notch medical board preparation, just to support future doctors preparing for the national licensure examination. His research on mental health, global surgery, public health, social science has been recognized at both regional and international levels in different international and regional conferences. Driven by deep sense of fairness, a system thinking mindset, and a strong belief in compassionate healthcare. Dr. Kevin's continue to work at the intersection of medicine, research, and advocacy. Just this is all about Dr. Kevin biography. Now you take your times to present an important topic on ethical practice in a modern surgical paradigm and future perspective. I will invite Dr. Kevins for interesting presentations.
All right. Thank you for the introduction. Am I audible for the audience or over before I start?
Yeah, You are audible. You can proceed with the
All
presentation.
right, great. I'm going to share my screen now. So yeah, good morning, afternoon, and evening to everyone, wherever you are. Before I begin, I'd like to thank you for the opportunity to share my reflections on a pretty relevant topic that intersects medicine, ethics, and technology. While I am a doctor by training, I approach this conversation not from the surgical field directly, but from a position that is concerned with how innovation can shape patient outcomes, systems, and trust. Today, we'll explore how ethical principles can remain foundational in the evolving surgical landscape, particularly as new technologies reshape the practice. So, just a quick disclaimer, I am not a surgeon by training. I offer a perspective shaped through active engagement with colleagues, grounded in frontline realities, along with my own research and interprofessional dialogues. My aim here is to offer a multidisciplinary, ethically reflective lens on innovation. So, here's how we'll structure this talk. First, we'll begin by grounding ourselves in the broader ethical foundations of global surgery. After all, surgery is not just about the OR, it's also a public health issue. Next, we'll look at how artificial intelligence and robotic surgery are transforming the surgical landscape, from decision support algorithms to robotic-assisted procedures. We'll examine what's currently in use and what's emerging. Then, this section about ethical challenges is the heart of our discussion. We'll unpack the specific ethical dilemmas that arise with these technologies. We'll touch on patient autonomy and consent in an AI-driven world, data privacy, algorithmic bias, and the changing role of the surgeon. Then we'll turn to solutions on what ethical best practices look like in implementation as future perspectives. We'll end with a call to action on how we can advocate for patient-centered, ethically sound innovation. With this in mind, let's begin setting the context. So, we need to understand where the greatest surgical needs lie. Over 5 billion people lack access to safe, affordable, and timely surgical and anesthetic care, all according to the Lancet Commission. This isn't just technical or medical gap. It's an equity issue, a justice issue to say. Access is limited in low and lower middle income countries, where even up to 9 in 10 people cannot access basic surgical services when they need them. When we talk about global surgery, it's not just the operating room. We're talking about maternal health, cancer, trauma, cardiovascular disease. These are all fields that require surgical access, making surgery an indispensable part of universal health coverage. And so we arrive at our core question. How do we ethically scale surgical innovation in a world so unequally equipped? This is where the classic ethical principles must guide us. These has already been mentioned earlier, so I'm not going to go into them in depth. So, especially when newer technologies such as artificial intelligence and robotics come into play, these will be our North Star. So, in the recent years, we've seen how fundamental transformation in how surgery is conceptualized, not just a manual skill, but as a system being increasingly integrated with intelligent technologies. So what was once science fiction is now slowly becoming reality. AI is revolutionizing surgery by embedding itself into every step of the surgical continuum. In fact, from diagnosis to preoperative planning to intraoperative navigation and postoperative monitoring. Take a look at the image here, for example. Just from this surgery here in the South China Morning Post, reports of a surgery being done in where the surgeon is in Tibet, but the patient is all the way in Beijing. So that sounds exciting, isn't it? Robotic platforms now support minimally invasive and even remote surgeries, just as what I discussed, improving access for underserved areas and improving surgical dexterity. So from surgeon-led to tech-augmented workflows, this shift marks a movement from how a traditional surgeon-centric model where decision-making and execution are distributed between human and machine. This leads us to a paradigm shift. The surgeon is not just a conductor, but also not just a solo performer. So as autonomy of these systems increases, so too the ethical dilemmas. We often hear that innovation is usually the answer, but we need to ask ourselves, what problem are we solving? And are we also creating new ones? AI and robotics promise efficiency, precision, access, but they also introduce complexity and risk. Much of AI's appeal comes from its promise, but in practice, that doesn't always fall within expectations. Regulatory systems struggle to keep up, and clinical trials validating AI tools are often lacking. As mentioned earlier, there's a quiet cultural shift happening. The surgeon's role is transforming. Even the patient too is navigating unknowns. How much do they understand about AI's role in their procedure? This leads us to talking about concerns such as accountability, trust, and bias, more of which we'll discuss later. Let's begin with informed consent. What does it mean to say yes to a surgery today? Let's begin by asking, when a patient gives consent, who or what are they trusting? Increasingly, the answer is not just about the surgery itself, but it's also the algorithm. Yet, artificial intelligence isn't easily explainable even to the one using it. Take a look at the figure on the right side of the screen here. This is just from a study here showing that while patients may feel adequately informed after AI-assisted explanations, there are still concerns about data privacy. AI can standardize and clarify risks, but also introduces new forms of uncertainty, especially when patients don't fully grasp on how these recommendations are generated. And let's just say if the surgeon cannot interpret the algorithm's reasoning, can they even explain it to the patient? This raises legal and ethical dilemmas about the validity of consent. Consent is not just a form. It's a contract, a moral one. Patients want to feel in control, especially when it comes to high-stake decisions. The takeaway here is that consent must evolve. It must go beyond just checking boxes. Ethical AI use requires transparency, but also accountability between and collaboration among surgeons, developers, and ethicists. Next, we talk about data privacy. Is the OR becoming a surveillance room? A rhetorical question to ask. When everything in the OR is recorded, tracked, and analyzed, who owns that story? AI needs massive surgical data sets. Patients may never know if their operation was used to train some form of algorithm. So, when this kind of data becomes centralized or hacked, what happens? It can even have lifelong implications for patient privacy. On the other hand, recording surgeries can even be used for quality improvement, surgical education, and even safety audits. But what if it's also being used for monitoring surgeon performance or for commercial purposes? While current protections in place, such as HIPAA or GDPR, are steps forward, they often lag behind the AI they're meant to regulate. While there are new techniques such as federated learning and differential privacy offer solutions, but implementation is uneven. Trust depends on transparency, but most patients are never told how their data will be used after surgery. So, can trust be engineered? Building trust in tech-mediated care requires more than just compliance. It needs clear consent models, the right to withdraw data, and systems that default to patient agency over corporate control. The bigger question in play here isn't just what AI can do. It's also who's it leaving behind. Technological growth in surgery is not evenly distributed. AI models may fail underrepresented groups. In fact, when data lacks representation by race, gender, age, or comorbidities, the algorithms perform worse for those excluded groups. Advanced robotic systems and AI-guided surgeries are typically concentrated in urban, well-funded, and established academic centers. while, in contrast, rural areas and low-resource settings can't afford the same infrastructure or even capacity. This creates a disparity, a surgical divide. Gaps like these raise fundamental questions of justice and fairness in surgical innovation. The risk here is that we are reinforcing a two-tier system, high-tech surgery for the privileged and outdated care for the rest. So, solutions must start with diverse data, inclusive development, and global partnerships. Policymakers must ensure that AI investments don't just widen gaps, but close them. We must frame that access to surgical AI not as a luxury, but a matter of ethical responsibility. So as we move deeper into the era of AI-assisted surgery, we must confront a pressing concern. Are we training surgeons or training technicians? With AI systems guiding, prompting, and even executing surgical tasks, young surgeons may no longer gain the depth of hands-on experience. Think of AI-powered instruments doing most of the work. What happens when the system fails? Can the surgeon take over effectively? Even clinicians can even lose their own physical exam intuitive diagnostic skills due to over-reliance on digital technology. As AI becomes more trusted, there's a danger that surgeons might defer to algorithmic recommendations, even when clinical judgment may say otherwise. This can erode surgeon confidence, turning them into decision makers, into passive instruments of machines and algorithms. So the question here is, who is ultimately responsible when things go wrong? Is it the surgeon who pushed through, the developer who trained the model, or the hospital that implemented it? The answer here is ideally shared accountability, but in practice, surgeons still bear the legal and moral weight, as per the captain of the ship doctrine. So, AI should augment, not replace human skill. Core surgical training must continue to emphasize manual dexterity, critical thinking, and decision-making under pressure. Trainees must learn with AI, but not depend on AI. So AI in surgery is not just a question of capability. It's a question of access, equity, and cultural fit. While high-income countries' HICs are optimizing surgical precision with AI, low and middle-income countries, or LMICs, face a different challenge. So this leads us to ask, how do you integrate cutting-edge tools in systems that lack basic resources? Many LMICs lack reliable electricity, broadband, or even tools, all of which are prerequisites in deploying AI or robotics in surgery. Even tools such as telesurgery or guided techniques can't function without these kinds of technology. Plus, on the other note, there's the cultural trust and patient expectations. In many LMICs, patients may view AI as alien or even untrustworthy, especially if we're going to talk about rural or traditional communities. Others might overtrust the technology, assuming it's flawless, which distorts informed consent and creates unrealistic expectations. So AI adoption must respect cultural values, communication norms, and local trust dynamics. Plus, AI ethics is still evolving in HICs, but in LMICs, when it comes to ethical frameworks, it's an entirely different story. Without local datasets, AI models trained on high-income populations risk making inaccurate predictions in lower and middle-income countries. So, ethical AI and LMICs must be locally trained, transparently governed, and equitably distributed. Some proposed ways on moving forward here can include public-private partnerships to lower costs and boost reach. Then, twinning programs wherein HICs mentor LMIC surgical centers. Local innovation where LMICs create low-cost AI platforms trained on context-specific data. These are not just idealistic, they're urgent, considering on what I brought up during the Lancet Commission earlier, about 5 billion people still lacking safe surgical access. Tech equity means nothing if half of the world is left behind. So, in the race to innovate, ethics is the compass. Without it, AI in healthcare is not progress, it's risk. So we go back to our 4 foundational principles of medical ethics. First, beneficence. This means designing tools that truly enhance diagnostics, surgical precision, patient recovery. For instance, AI-assisted telesurgery can extend specialized care to underserved areas, reducing surgical site infections and post-op complications. Next, justice, fair access and representation. It must not deepen existing inequities. Biased algorithms or access limited to wealthy urban hospitals betray this principle. Datasets must represent diverse populations to avoid racial, gender, and regional bias in its predictions. Plus, there's also the idea that access must also be geographically inclusive. Then, autonomy. Patients have the right to know what is the AI recommending, why, what are the alternatives. AI must be explainable. Patients need transparent decision-making. Informed consent in AI context must evolve to include disclosure of limitations, risks, and human oversight. Autonomy means AI should support decisions, not silently replace them. Then, non-maleficence. Do no harm. AI errors, misdiagnosis, or biased outputs can be life-threatening, especially in surgery. Poor regulation, lack of accountability can lead to unchecked harm. Ethical deployment must prioritize things such as robust data protection for our privacy, transparent accountability chains, and ongoing monitoring for harm or bias. Even AI that works 95% of the time is still dangerous when lives are at stake, because there's still that 5% that we need to be worried about. So ethics is not just theory, it's architecture. We need structures that translate ethical principles into everyday clinical practice. Ethical AI in surgery is not just about code or compliance, it's about how decisions are made, who makes them, how outcomes are measured and improved. We shift from what is right to how we build it right using these pillars. First, stakeholder involvement. We engage voices beyond developers and surgeons. We need to include other disciplines such as ethicists, rural clinicians, legal experts, public health leaders, and of course, the patients themselves. Community participation ensures that artificial intelligence is not just some top-down imposition, but also a tool for shared benefit. Next, continuous evaluation for AI outcomes. Tools must undergo monitoring and evaluation, especially in real-world settings. Metrics to consider include clinical accuracy, health equity impact, patient satisfaction, and error tracking. This feedback loop helps prevent harm, uncover hidden biases, and adapt to the ever-changing needs. Next is cross-disciplinary governance. No one field can govern AI alone. Multi-sectoral oversight, bodies that combine clinical insight, technical knowledge, ethical scrutiny, and legal accountability reduces the blind spots. Then, of course, training beyond the technical. Teaching surgeons or developers how to use AI is not enough. We must also teach them why, when, and if to use it. Incorporating bioethics, cultural competency, data justice, and patient communication into training programs is important. Ethical awareness should be a surgical skill, trained, practiced, and expected. While these pillars help ensure that technology in the OR doesn't just cut, it heals, includes, and respects. So, as AI evolves, we must maintain our commitment of what makes care human. The promise of AI in surgery is precision and reach, but the heart of care remains human connection. Machines can optimize, only humans can empathize. We must ensure that AI doesn't outpace our ethical reflection or displace the surgeon-patient relationship. To quote Dr. Ian Malcolm in Jurassic Park, it's not just about being preoccupied whether or not they could, or they didn't even stop to think if they should. This is a warning just as relevant as today, especially in technology. Automation should support, not supersede, clinical judgment. Surgeons must remain active agents, not passive executors and instruments of algorithms. The system may predict, but the surgeon must decide. Preserving humanity and innovation, not just to serve efficiency, but it must also serve dignity, equity, and trust. In every surgical theater of the future, let it be said, a human is still in the room. So, as we engage with surgical teams or trialing AI tools, two things always arise: hope and hesitation. On one hand, there's always excitement about improved outcomes, speed, and precision. On the other hand, there's anxiety. What if the AI is wrong? What if I rely too much on it? These are not just technophobic fears, they're really actual ethical things to concern, and even experiential. Everyone's always nervous about new technologies in one way or another. Of course, who's accountable if a patient is harmed because of AI? After all, there are different kinds of stories that we can hear already, whether if we just search up on the internet or just hear about it someplace. And of course, there's still the legal concern. Who is accountable if a patient is harmed? Well, AI can inform, but it must never override human responsibility. Of course, knowledge must be coupled with humility, especially when AI offers false certainty. Real wisdom lies in knowing when to listen and when to doubt the algorithm. We need a culture of ongoing reflection, not just blind adoption. And we need collective dialogue against different disciplines. Talk about this. So AI can suggest, but surgeons must still decide. So what can we do? Innovation is not just in the OR, but it can even begin as early as the classroom. Let us embed ethical reasoning into surgical education, because a surgeon who can question why, not just how, is a safer, wiser healer. AI is being trained with data from everywhere, so it must be built for everyone. Support international research partnerships and ethical frameworks. Let voices from lower middle income countries, rural systems, and indigenous health wisdom help shape what responsible AI looks like. This is a shared future, and we must co-author it globally. Inclusion is not just a buzzword. It's also a clinical necessity. If your AI doesn't see everyone, it fails someone. Let's advocate for diverse data sets, gender-sensitive design, and access that doesn't discriminate based on geography, wealth, or identity. The future of surgery isn't just surgical. It requires voices from ethics, law, technology, anthropology, education, and even patients themselves. Stay open to these hard conversations. Stay open to even being wrong from them. It's in these kinds of dialogues that better futures are born. This is not just about a revolution of technology. It is a human revolution. Let's rise to meet it not just with skill, but with integrity, courage, and collaboration. And with that, in all our talk around AI and surgical robotics, we must ask, are we advancing because we can or because we should? Innovation alone isn't enough. It becomes meaningful only when it is human-centered, improving lives, widening access, and preserving dignity. Otherwise, we risk building systems that forget compassion. Ethics can not always just delays to innovation. They're not barriers. In fact, they're bridges, guiding us from what is possible to what is right. They make us pause when we're tempted to rush. And of course, in healthcare, that pause saves lives. To quote Dr. Ian Malcolm again from Jurassic Park, about how scientists were so preoccupied whether or not they could, they didn't stop to think if they should. This does not just apply to ideas of prehistoric dinosaurs, it also applies to science itself. So, Let's not make that kind of mistake and heed that warning. Advance with caution because lives are on the line. Creativity because problems are complex. And care because without empathy, where is the humanity? Progress isn't just about how fast we move. It's about who you bring along and how safely. Let us be the voices that leads not only with code and computation, but with conscience, courage, and clarity. Let us ensure that the future of surgery is not only possible, but ethical, equitable, and truly healing. And with that, this ends my presentation. That is all.
Wow, what a presentation, Dr. Kevin. Thank you very much. You brought, I think this is our challenge global community. So it shows it's good that surgeries are done remotely using robotic assisted surgical procedures and AI assisted surgical interventions. But the ethical aspects of robotic and AI assisted surgeries should be addressed. So you have presented us with a very impressive and up-to-date aspects of these issues, these modern surgical interventions. I would like to say thank you again. So especially from your presentation, there was an expression that says the system may predict, but the surgeon must decide. This is really impressive. This is really, really impressive because a human-made algorithmic surgical intervention should never override the roles of very knowledgeable and experienced human surgeons. So that's a very good explanation. So having said this, I would the time is now open for questioning and discussions. I think if Mr. Siraj is with us, Mr. Siraj, are you listening? Can you
Yeah, I'm listening you,
present your presentation?
Nursin.
Or
But I have
you can just share your file. Shall we?
for Demeka to display since I cannot. Can you hear me?
Yeah, we can share it. Then
Okay.
we will go
So
to the next.
can you hear me now?
Discussion.
So
Yeah, I can hear you.
can I share you
Yeah.
to display because I cannot since I've told. So I have.
Okay. But the issue now is, do we have time left for the presentation now?
I have already shared.
So Demeka, can you
Siraj
display? Can you share the slide?
I already forwarded for Nursin to share because I have faced a challenge.
Thank you. So,
Mr. Nursin, can you share?
Okay. Yeah, but my point is that we do not have time for the. We do not have time for the presentation because we are only left with 20 minutes, and this 20 minutes might be for questioning and answers, I think.
Okay.
But there is
do
also
it for a few minutes if that's okay.
Okay.
We can do it for
Let's
10
give it a
minutes.
try.
Yeah, please. Thank you.
Okay. So Demeka has sent me the document. documents. I will try to open it if it is opening here. Okay.
What? Nuri, you can share, I think, if
I
time
don't think,
allows for the presentation.
yeah, since I'm using
Check your
my mobile phone, I don't think it will be easy for me to display it using this one. Okay, anyways, I'm trying it.
I think Tamaka, you
Yeah,
can
is it?
send too, and
Is it in the
for the
WhatsApp
sake
group?
of, can we?
Can
You can.
I send for you, Dr. Nagar?
Yeah, you can share me. I can share with.
Okay. Okay.
I think for that, until then, for the sake of time, you can proceed with the question and
No,
answer.
I already forward for your Telegram, Dr. Nagar. Can you try, please?
Yeah. Yes, I'm trying. Okay. I don't know. It says unsupported document type. Please select an image or PDF. It says.
Yeah, that was a problem for me also.
But it is PowerPoint, yeah?
Yeah,
For
it's a PowerPoint document that I shared for Dhammaka.
okay. Yeah. Once.
Maybe if you can send it to me, I can share from my hand if that is okay. If you can send me the document, I think that might be more convenient.
Okay. So I can make it.
Oh, okay, yeah, yes.
So, Dr. Nagat, can you unshare? This is a black ink document, I think. So that's
Yeah,
preferable so I can share us.
I stopped it.
Yeah, thank you. So she will share us now.
I'm trying to open.
Have you received it, madam?
Yes, one second. See. Sorry, everyone, just a minute.
So yes.
Thank you for your patience, everybody. So we will try to talk about some issues related to the practical challenges of vulnerable populations in research. So most of the issues have been tried to address by the first presenter, Dr. Abidin, and my pointers of views are usually related with the vulnerable groups of populations in clinical research, especially. So next slide, please. Next, also, these are the presentations outlines what I'm going to cover in this discussion. Next, please. So the first thing, what are the vulnerable populations in research? So vulnerable populations usually, when we say vulnerable individual or group of people, they are at increased risk of researchers collecting data, exploitations during dissemination of results that they are not interested in. So due to certain factors that limit their ability to protect themselves and their interests also. So these are groups of individuals. Actually, the factors that exposed them for increased risks during clinical research, especially, are two factors: extrinsic and intrinsic. So extrinsic factors that endangered those individuals or groups of population are usually economic factors like poverty or lack of education and the likes. And the intrinsic ones are severe illness, actually health-related issues, and intellectual disabilities, also the emotional developments, and also developments in psychological aspects. So peoples who are vulnerable, endangered during clinical research usually are the poor populations from every community and elderly populations during data collections, children's due to different factors related to inability of their capacity, underdevelopment, and the likes, and disabled populations also, and the likes are minorities. So why are they considered as vulnerable? So when we say these groups of populations are vulnerable, because they are not relatively empowered to protect themselves when we compare them when we compare with that of a researcher or a data collector. A data collector or researcher or an investigator is more empowered during data collection or conducting clinical research. So they may enforce those individuals that are vulnerable to give the information or the lacks for the purpose of the research, while those individuals or groups of populations are not able to protect themselves, their interests, their privacies, and the likes. So due to socioeconomic factors, legal and medical, and even political factors, they may have end up with such vulnerability. So category of vulnerability. So we can categorize vulnerability in terms of, actually, we can say it factors also. So health-related category. So people in such scenario, they may have been in critical vulnerability, especially people with chronic illness, people with mental illness, we can categorize as health-related vulnerability. In case of socioeconomic, we can say economic factors like poverty, education, house insecurity, and the likes. This population may end up with enforced giving of information and the like. So the other category we can say is geographical. So rural population or people living in conflict areas or displaced peoples living in the refugees and the likes, they may have also a factor that make them endangered for giving their information. They are in the situation that they cannot protect themselves, their views, their privacy information, the likes, due to such categorical vulnerability. And the other one is political or legal status vulnerability. For example, patients with undocumented migrants may have situation that they have to choose to give their information that is kept to be private, unless they may not allowed to live in the area they are migrating in. So this individuals are vulnerable for research. And the other is cultural and linguistical barriers, categorical vulnerability of individuals. Next, please. Next slide, madam, please.
Yes, it's on next slide, I think. Yeah, I think it's just network.
Yeah, yes, nice. Thank you. So why it is important to recognize vulnerable populations or research for research? So why we know that people with such classifications or factors are is increased risk for exploitation and the likes during conduct of research. So knowing this is important to ensure that ethical standards are maintained in research conducting on such peoples or groups of individuals and populations. And it's also used for considering specific ethical considerations and protections of those individuals who are in the maximum risk during data collection, conducting researches, taking information related to their privacy, and it also used to protect such groups from exploitation, stigmatization, and harming in clinical research. So research with such individuals or vulnerable participants actually raise practical challenges, especially in relation to their consent. Actually, in the first presentation, there are very good explanations about consent. Consent is not simply merely a signature from an individual participating in research. It's a process of gaining voluntariness, full voluntariness to participate in research and also to in clinical services. So we may get a signature from an individual who is going to participate in research or study subject as working as voluntarily as a study subject, but the consent is not fulfilled unless there is a full maintenance of voluntarily participating in clinical researches. So number of challenges may arise in such individuals when they are encountered in research or investigations, clinical investigations especially. So they may have issues of accessing care or services. So to get an access due to transportation, due to digital device and technological illiteracy, they may think that giving information, participating in the research may be a requirement to get a service. So they may think this. So this is a practical challenge. And the other challenge is communication barriers like language literacy, cultural misunderstandings, lack of trust in the institutions. This may be a practical challenge in people with vulnerability in research. For they may think that if I am not interested in participating in the research, I may not get service in this institution. So I have to have taking part in the research. I have to give my private data for the investigator to get a service in the institution. So these are practical challenges actually. The other is ethical dilemmas, and especially in getting informed consent. Consent is a complex process of getting willingness, voluntariness to take part in clinical research in such groups. So this actually patients or clinical study subjects, we can say, are in increased risk of danger or exploitations in research, because they may think that if I am not involved in such research, if I am not give my consent to get in participate, I may not get an access for care what they are primarily came to the institution. So there are many other concerns, including the privacy concerns, legal and policy restrictions, that they may even lack documentations of legal status of their medical status and the likes. Even they may think that they may lack their documentations of legal status, medical status, and the like if they are not participated in that research. So these are actually we face in studies or clinical investigations in vulnerable populations, including children, elderly people with disabilities, mental illness, individuals, and the likes. Actually, if we want to get a consent for those individuals, especially in pediatrics or child, so consent usually is surrogate or proxy consent from their parents or legal guardians. But as much as possible, as far as consent is a process of engaging individuals with full willingness of their interest, we have to involve them to the maximum understanding of their willingness. We have to consider that they may involve it in making a decision in to take part in the clinical research that is going to be conducted, including their private data, information, even biological products also. Even though the signature or the final decision is surrogate or proxy, but the individual should be participated. So we have to think of various strategies to ensure voluntariness of those individuals who are vulnerable by nature, vulnerable by different factors, which is intrinsic or extrinsic. So if we think of strategies to minimize the risk of inappropriate consent or maximizing the voluntary participation in research, we may design various strategies, including, for example, if we think of individuals based on their ages, we have to appropriately design age-appropriate communications, like for pediatrics who are kids below school age, adolescents who are not able to give a consent, but they can communicate and decide and understand what we are going to do on them. So we have to design age-appropriate communications for them. And the other one is training of researchers to maintain the voluntariness of individuals and protection of risks of those people with vulnerability, increment from the society, of the community, or the clinical subjects. And also we have to maintain an ongoing consent processes, starting from discussion, briefing, information adequateness, and involving those parents and the likes. The other issue, the last point actually I want to raise is what are the institutional review board issues related to people with vulnerability. If we get as IRB members, for example, or issues related to IRB, if we get clinical proposals or protocols that have in connection with people with vulnerability or vulnerable groups of individuals. So what are the main issues? Actually, vulnerable groups involved in the research should be in a standard maintenance or in maximum safeguarding of those individuals to minimize the risks of harm and exploitation of those individuals. So there should be a proper obtainment of informed consent that avoids the presence of therapeutics misconceptions, mistrust of institutions, even individuals who are get involved in research as an investigator or clinical data collectors. So there should be an assessment of decisional capacity in critical patients recruited for research. Elderly people with critical illness or comorbidities may be in less capacity to decide, but we have to get involved with them. We have to assess their capacity to decide. And finally, we may even engage a type of proxy consent from legal representatives or such like. So researchers and other institutions who overtake or oversee clinical researches, such as ethical review committee or ethical review boards and the likes, must work to decrease risks of harm for vulnerable participants in general. And cultural competency as a practical solutions also can be identified. Cultural competency trainings of professionals who pursue research, for example, anyone involved or trying to conduct an investigation on people with high vulnerability should have a cultural competency, or what cultural issues related to those individuals should be understood easily. So community engagement and participatory approaches is also can be considered as a practical solution or during IRB issues of reviewing protocols or proposals involving people with high vulnerability, emphasizing also the need for inclusiveness, compassionate approaches, and context-aware practices among researchers, clinical data collectors, and even the member who are working in IRB member should be also focused. So finally, we have to have an encouragement of ethical sensitivity in all interactions involving people with high vulnerability. So this is actually in short what I want to transmit, because more of the ethical issues have been even discussed in the first presentation by Dr. Abid. Thank you very much.
Okay, thank you very much, Mr. Siraj Ahmed. So it was a very great presentation, and we thank you for your time management. You have just presented it timely. I think we took time, and we will just make the questioning and answer session a little bit shorter, and then we will have a few discussion points that needs to be forwarded, and finally we will have a closing remark, and that would be done by our president, Professor Adewsala. So the floor is now open for answers. I only accept few questions because we are running out of time. So you guys are welcome to forward your ideas. Thank you very much. Anyone who wants to forward or to ask some questions for the presenters so that we can have ideas getting entertained. There are appreciation comments in the chat box. That is a very good thing, and we also thank for our presenters for taking time to prepare and bring us with the most up-to-date information on the aspects mentioned above. So I think if we have not questions to be forwarded, we may just let some few individuals to forward or to as a point of discussion on today's presentation. So if you have something that you want to just add, you are also welcome. If there is no one who wants to add or to talk some discussion points, we can just directly go to the closing remarks. That closing remark might involve about the next steps on the in our next meeting. What could be what are the possible meeting ideas so that we can be prepared for that. Professor, if you're listening, you may say something about today's meeting.
No, I think my hand.
Yeah. I think someone is raising hand.
Yes.
Okay, Yusuf, you can proceed.
Yeah, just a quick one. So thank you very much, and everyone, for the wonderful presentation. This actually gives a deeper insight into the ethical issues regarding research, that are conducted all over the world. But my comments and also question is mainly on surgical procedures that are being practiced in LMICs. I'll take Sierra Leone as an example, where we have a lot of NGOs who fund free surgical services in remote areas like hydrocele, hernia, and other general surgical conditions. And in my experience in most of these surgical services is that the procedures to follow ethics is not rigorous. Wherein, of course, we know Sierra Leone has one of the highest surgical unmet needs, around 85 to 90%, according to a research conducted in 2013. And there have been a lot of intervention to close that gap. So one of the few are the philanthropists who bring in their funds, and these funds are being given to hospitals and other institutions to perform these surgeries. So the ethical issue here is one, sometimes the resources that are being provided to support these surgeries are not enough. So like medications and even some surgical materials. So the surgeons are often left in the dilemma to see that they do justice to their service. So, and often when we do write back to the partners and requesting them, they will not respond, and it is often left with the responsibility of the implementing partners to see that they try to see to try to protect the service users as much as possible. And we are often left in the dilemma of you having people who are desperate for the services, and another situation wherein the resources provided for these services are inadequate. And if you proceed to provide these services, with that magnitude, there will be one or two ethical breach, such as the risk of some surgical site infections, okay, and some other things because of inadequate medications, or maybe the materials are not enough. So this is just a reflection, but I just want to maybe hear what are some of the considerations in such situations. Thank you very much.
Okay, thank you very much, Yusuf, for your insights. I think if I understood your point, there are
Can't quite hear you. I don't know if it's my network or yours.
Resources are limited and patients are where there is high patients. So this is most of the time. Is that okay? So sorry for the interruption. So I think Yusuf has raised a very important point about limited resources, or in setups where resources are scarce and the burden of surgical patients is high, and there are dilemmas that are just for the clinician or for the caretaker. There are okay. Can you hear me, guys? Is
Yes.
that audible?
Yes, I can hear you now.
Okay, so anyone who wants to forward Yusuf's question or any point, maybe you can add. Otherwise, it is a very common thing, especially in conflict-affected zones, conflict-affected environments. There are resource limitations, and the burden of surgical patients, especially trauma patients, is high. So in such a situation, the clinicians are overburdened in making the appropriate decision, which is ethical for most of the patients. So this is something that we need to discuss in our next meeting. I think we can just come up with some important solutions. So having said this, if there is someone who wants to add points that are not mentioned yet, I may allow one person to just raise one point. Otherwise, we will directly go to the closing remark. And I would be happy if our President, Professor Abdulsalam, makes the closing remark. Thank you very much.
Thank you, everyone. That was a brilliant session. I really want to say a million thanks to everyone, to the entire Institution Review Board of the Operating Room Global TORG. And I also want to say thank you to the Director of Global Research in TORG, that's Assistant Professor Nurusin, for taking up this role even in short notice. Thank you so much. I want to say thank you to the organizers, to the facilitators, to the session chairs, to all the speakers. I want to say thank you to all the leaders, the partners, everyone that connected from all over the world. Thank you for joining the session. I must say that this Congress actually marks the pivotal moment for TORG-IRB as we actually celebrate our ethical leadership in surgical research. It's been, the journey has not really been long with TORG-IRB. It was inaugurated recently, just a few months ago, and having an inaugural Congress today means that this is just more than an event. It's actually a landmark affirmation of the role that ethics must play in advancing surgical science, especially as we have seen in all the presentations in low resource settings, especially for vulnerable populations as well. Recently, as we are aware, and as part of the introduction from the Director of Global Research at the start, the TORG-IRB actually was registered with the United States Office for Human Research Protections. That was recently, and also got this FWA, that's Federal Wide Assurance, for another 5 years. And that implies that whether you are leading a multi-country trial, whether you are conducting community-based participatory research, or you are having innovation in surgical education, TORG-IRB is actually now positioned internationally to review and give you an approved ethical compliance for your work. So let this Congress today, let it inspire everyone. Let it actually equip us to do research that not only heals, but honors humanity. Like the second speaker actually mentioned that, AI can actually can give you instruction, give you suggestions and everything. The human would still need to decide. So we have learned a lot from today. Me as a person, I've learned a lot from today. We've heard a lot of insights that actually reinforce our belief that ethical excellence is not optional for everyone. It is essential. We need to uphold the highest standards in research oversight and actually promote a culture that is of trust, that is of safety, and that has justice in global surgery. We learned about the autonomy, justice, the principle of non-maleficence and beneficence as well. There was a lot to take home from today's session. So I really want to say thank you, everyone. Thank you to the entire team. Thank you to the TORG Global Training. Thank you. I believe we now all know that this TORG-IRB qualification-wise, protocol-wise, and registration-wise, they are equipped to actually review and to monitor global surgery research protocols, so they can support you and provide ethical oversights for actually invasive surgical procedures as well, including clinical trials. They can support multinational audits. They can support national audits. They can support training-based research. They can support quality improvement projects or anything you want to do that promotes equity, maybe safety in surgical research, and including vulnerable populations as well. So in TORG, we're actually we want to uphold ethical research excellence for a safer and more than just the surgical world. So thank you so much, everyone. Thank you for joining, for taking the time out of no time to connect. I believe you have seen all the documentations in the chat box. Maybe if you have not seen them, you can go through the chat box. There should be the 3 presentations from tonight in the chat box. And this inaugural Congress, it's accredited with 2 CPD points, which is going to be for everyone. If you have participated tonight, we will look up the records and issue the certificate to everyone. There is also an evaluation link, which I'm going to drop in the chat box. Let me see if I can quickly drop that. So it should pop up on your screen immediately after the session is ended, but I'm just going to drop that in the chat box as well so that you can see the link. Just give me a second to pull up that link for evaluation and certification. So you can fill it out. You can let us know what you learned from today. If there is a topic that you would like to see in the next Congress of the TORG-IRB, you can let us know. You can leave us a comment. If you have a recommendation or any comment or anything whatsoever, any suggestion to improve the experience for tonight, feel free to send that as an email. So the email of the TORG-IRB is actually torgirb@operatingroomissues.org. Maybe one of the members can drop that. Maybe one of the members can drop that in the chat box as well. So let me someone is saying they can't see the last presentation. I have it in the chat box. Let me just drop it again before the session is closed, and I'll drop the link for the evaluation as well. I know we have taken much of our time. We apologize for taking your time. It should be 2 hours anyway, but we have used more than that. So we are really sorry for taking your time. I'm going to drop the evaluation link. Just a sec. I'm trying to find it up. So that's the evaluation link in the chat box. So in case you don't receive that on your browser, when the session is ended, you can actually copy that link and save. And I'm going to drop the last documentation again, just for the benefit of those who may not have received it. So that says practical challenges with vulnerable populations. And I'm just going to redrop that in the chat box as well. So thank you, everyone. Thank you for joining. Thank you for connecting. On behalf of the TORG-IRB chair, he's sending his greetings. He's been strong for a while, and we wish him quick recovery on every side. A million thanks to the team for the commitment, for the leadership, for helping to uphold the highest standards of ethics, even in TORG and beyond. So thank you, everyone. Feel free to reach out at any point in time. If you have any question, if you need anything, or if you've got suggestions, or if you want to support our training, I could see someone sending on the group that if you want to collaborate on research, so you can actually reach out to the global research team. We also have some researches ongoing as well, which are actually multi-country audits or projects. There is one on AI-assisted surgical coaching. As we have seen during the second lecture, that explained about the ethical aspects of AI, of robotics, and we shouldn't not just depend on results or on training from high-income countries. We should consider the LMICs as well. That's the AI one, assisted surgical coaching. So we want to use neurosurgery procedures, videos, live demonstrations to actually train AI to develop an application. So that is that about the AI one, which we are going to start soon as well. So if you see any of our posts in relation to researches, you can collaborate, you can fill out the interest forms, and hopefully we will reach out and connect you with the right team. So thank you, everyone. Once again, good evening, good morning, good afternoon, depending on your time zone, and hopefully we see you again. So expect over the next few days, maybe 5 to 7 working days, to get your certifications by email. So you can fill out the evaluation and certification form. Either you are a member or not. Today's Congress is free for everyone, so you are going to get your certification by email. Just fill out the evaluation and certification form, and we will send that out to you. So thank you, everyone. Thank you for joining, and good night. Have a nice day. Bye. Bye.
Okay. Thank you, everyone. Good
Thank you
night.
so
Yeah.
much, everyone. Goodbye.
Thank you, everyone. Bye. Good
Thank
night.
you.
Good night. Good night. Good night.
Thank you. Bye.
Bye. Bye.
Bye.
See you
Bye.
the next.
Bye.